And so hopefully I will have this lecture up on YouTube within a couple of days, and you'll have a link to YouTube that you can, that'll be directly where all the links have been had. You won't have to use it on MP3 player. You'll just be able to get it directly to YouTube. My mentor told me that was the thing to do, so that's the way I'm going to do. We're going to talk about the third chapter, the last chapter in our exam, okay? We've talked about the blood, which was the transport vehicle. We've talked about the heart, which is what makes everything get transported. That's the pump for the system. Now we're talking about the conduits or the roadways or the tunnels or whatever you want to talk about. It's the blood vessels, okay? And these are as important as the other parts, because if without the blood vessels and without the mechanisms of regulation in the blood vessels and without the ability to direct regional blood flow and have exchange going on, it really wouldn't matter about the other two, okay? 5 major types of blood vessels. We have arteries, which carry blood away from the heart. Remember, okay, it's not always oxygenated blood, because we talk about the pulmonary artery coming out of the right atrium, the pulmonary artery is carrying deoxygenated blood, okay? But the definition carry blood away from the heart will hold you in good stead. Arterioles are arteries that have branched. So we'll have big arteries, huge arteries, named arteries, even smaller named arteries, and we'll get down to a level, okay, just before we get into the capillary bed, or just before we have an arteriovenous anastomosis, where the vessels gets down to the size of the arterioles. So these arterioles are not named. We've gone through the named arteries, gone through the larger, smaller, and even smaller named arteries, and then maybe even some arteries that don't have names on it. We're down level to the arterioles, and the arterioles are actually the last branch of the artery system before you either get into the capillary bed. This is the capillary bed, or you either get into an arteriovenous anastomosis, where you're going to bypass this capillary bed. Okay, the capillaries are where all the action occurs. In other words, that's where oxygen is exchanged, that's where CO2 is exchanged, that's where waste products are given up by the cell, that is where nutrition, which is carried by the blood vessels, is given to the cells, okay? And so this is where everything occurs. This is the site of the major work. This is the whole reason for everything else, okay? If this is the capillary bed in the lungs, this is where O2 and CO2 are exchanged, okay? If this is the capillary bed around the small intestine, okay, this is where nutrients are being absorbed, okay? If this is the capillary bed at the cellular level, around every cell, we have a capillary bed around every cell. This is where glucose and amino acids and O2 is being given to the cells, coming out of this capillary bed into the fluid, interstitial fluid, and then being absorbed by the cell. So this is the reason we have everything, because this is where the hard work is done, where the exchange of nutrients and gases are done. Then after we've had our exchange here, we need to collect this material. And we're going to do the same thing. Arteries, arterioles, capillaries, venules, veins, big veins, back to the heart. So it's really not hard, okay? And then the veins carry blood back to the heart. Arteries have 3 layers. Most of the vessels have 3 layers. They have a tunica, okay, tunica intima. Intima just means inside. In contact with the blood, it's lined with simple squamous epithelium, and it's continuous with the endocardial layer of the heart. We would like everything in the entire cardiovascular system to have a smooth layer. We do not want turbulence, okay? If we have turbulence, the possibility exists that we're going to form a plaque or a clot. And certainly we don't want either one of them, but we certainly don't want a clot that may loosen up and go some other part of the body. So we have simple squamous epithelium, okay, as part of the tunica intima. And so at the level of the capillary, all we have is a layer of simple squamous epithelium and a basement membrane, because we want exchange to go on. So it's a very thin layer. We have a tunica media, which has circularly arranged smooth muscle. That smooth muscle obviously is not voluntary, okay? It's involuntary muscle, and it's used for auto regulation. Okay. If we do not need to perfuse this capillary bed, then we are going to utilize that smooth muscle in these very small arterioles and shunt the blood around the capillary bed. And an example would be if we're in our sympathetic fight or flight reflex and we're not doing GI digesting, okay, then we're not going to perfuse the small intestine. Now, I mean perfuse the small intestine, we're not going to perfuse the small intestine for purposes of absorption. It's not that we're going to not perfuse the small intestine for purposes of staying alive. That's a different thing. This is for the purposes of digestion. Digestion, is decreased during sympathetic response. And so that would be an example of the circularly arranged smooth muscle. Or if we got into a situation where we were hypotensive because of blood loss, we would need some of these circular blood vessels would constrict down, okay, to try to preserve blood. Remember, at all costs, we need to preserve blood to the heart and to the brain. Can constrict or dilate, vasoconstriction or vasodilation. And then finally, we have the tunica extern, okay? It may be as little as a few collagen fibers with a nerve fiber and a lymphatic vessel, okay? So it may be as small as a few collagen fibers with a nerve fiber and lymphatic vessel over the top of it. In other words, if you are doing a dissection of a blood vessel, and we're talking about some of the smaller blood vessels, it's just almost like a filmy white substance on top of the blood vessel, and it doesn't have very much substance to them. In fact, you don't sew it; you actually sew the muscular layer when you repair a blood vessel. Now, in the larger blood vessels, in the smaller blood vessels, we don't need a blood supply to the blood vessel because the blood vessel is so small. It can, through the process of diffusion and those other processes we learned in Anatomy and Physiology 1, it can maintain its own blood supply. But for the larger blood vessels, like the aorta and the carotids and something like that, we will have a vasovasorum, which means we'll actually have a blood supply to the outermost layer of the blood vessel. And that's only in the larger blood vessels. And that's because they are much thicker. The aorta obviously is much thicker than a one-cell capillary. Types of arteries, we have elastic conducting arteries, okay? Aorta, common carotids, subclavian, vertebral, pulmonary, common iliac. Primarily, when we think about the elastic arteries, we think of the aorta, common carotids. Why do we call them elastic? Because remember, the aorta is going to take the full pulse of the arterial system as it comes, full pulse of the heart as it comes out of the heart. So the aorta is going to expand with that pulsation, with the ventricular contraction, okay? When the ventricle relaxes, then the aorta, which is still going to have blood in it, is going to relax. So it needs to be elastic and a conducting artery. We do not constrict the aorta. The aorta is not one of those vessels that constricts, that undergoes vasoconstriction or vasodilatation. Same way with the common carotids, okay? Common carotids are elastic arteries. We do not want that pulse coming out of the arch of the aorta, going up to the carotids and going inside to the brain. We want a continuous blood flow. We don't want a pulse blood flow going into the brain. And so these are some of the biggest blood vessels. They're 2.5 centimeters. If you don't remember much about metric, 2.5 centimeters is an inch. So the aorta is an inch or maybe a little bit bigger, okay, in diameter when it's not dilated. And some of these vessels in the carotids are about half that size. And then some of these elastic arteries can go down to 0.5 centimeter, which would be about 1/3 of an inch, okay? If you're going to go into the healthcare field, you're going to have to learn the metric system. If you're going to go into the healthcare field, you're going to have to learn the metric system at some point. Elastic arteries are the largest arteries. They're near the heart. They have the highest pressure. We will look at this a lot, okay? Here are our elastic arteries and arterioles and things like that. They have the highest pressure. They have they actually still have a systolic and diastolic pressure. Because systolic is when the ventricle contracts and that pressure pulse wave comes out, then the ventricle relaxes. They have the fastest blood flow and smooth blood flow because they are large blood vessels. There's nothing to impede the blood. There's not a whole lot of branching there. Okay, not a whole lot of branching, and they're large blood vessels, so they have a very smooth blood flow. Our next blood vessels are our distribution. Okay, so first were our blood vessels, which accepted blood from the heart and essentially, I think, of dampening that pulse pressure. Okay, so now we got to our distribution arteries: brachial, femoral, and splanchnic. Brachial, femoral, and splanchnic. If we were doing this as a face-to-face class, I would give you a list of vessels that you would need to know. But obviously, there's not a whole lot of point of asking specific blood vessels because you have your books there and your notes there, and you can look them up. So that as far as lab practicals and things like that, lab practical, with the exception of the heart and kidney dissection, where we look at the videos and actually answer questions, you won't have a practical or won't have a matching per se that will ask you to identify a blood vessel. And like I say, it's really there's really no point in it because all you do is just look it up. These are muscular, so they're distribution. Okay, think about the brachial artery is going to distribute blood flow to the upper extremity, and the femoral artery is going to distribute blood flow to the lower extremity. They are smaller in diameter, 6 millimeters to 0.5 millimeters. If you remember millimeters, that's 10 to the minus third, or it's a thousandth of a meter. They're moderate in size. They distribute blood flow to specific organs. Pressure and velocity are decreasing. Okay, pressure and velocity are decreasing because we're further away from the heart. We're further away from that pulse, and so the pressure is decreasing, and the velocity was also decreased. They're less elastic but have more smooth muscle. Now we're getting to the point where if we need to, especially in the smaller arteries, we can undergo vasoconstriction and vasodilation, which is what this says here. 0.3 millimeters to 10 microns. We're now talking about arterioles. Okay, we're talking about arterioles or meta-arterioles. Just so you will see this listed as either arterioles and meta-arterioles. They're really the same thing. We're talking about 0.3 of a millimeter, okay, which would be 0.3 of a thousandth of a millimeter, okay, to 10 micrometers. Microns are 10 to the 6th, okay. Milli is 10 to the minus 3. Micro is 10 to the minus 6. Nano is 10 to the minus 9. Pico is 10 to the minus 12. Okay. These are certainly through nano, because if you're going into the healthcare field, or if you read about the healthcare field, or actually they're going to have nanotechnology for other things. Okay. But you certainly will be dealing with nanotechnology, injecting either medications directed into specific organs, cancer therapy directed to specific organs, maybe stem cells directed, but there are even diagnostic things that are going to be on the level of a nanometer. A nanometer is 10 to the minus 9, okay? So it's not necessary that you learn all these divisions between, but there's certain things that you need to learn, and millimeters 10 to the minus 3. Micrometer or micron is 10 to the minus 6, and nano is 10 to the minus 9. We know I'm going the other way, okay? Kilo, mega, okay, tera. We know I'm going the other way because when we get ready to buy computers, we want to know how many bytes we're buying, okay? So these are the smallest blood vessels, okay? These are the smallest blood vessels in the arterial circulation. Obviously, you can't see these; they're microscopic. And so these are the ones here that are going to decide if you're going to perfuse the capillary bed, if you're going to perfuse the capillary bed or not. They're also the ones that they're going to turn into capillaries. So these small arterioles, meta-arterioles, going to turn into capillaries because it's going to be at the venous arterial junction. This is where the perfusion is going to occur. They regulate blood flow into the capillaries using the precapillary sphincters, okay? This is blood flow coming into the capillary bed. You can see the red blood, you can see the arterioles, meta-arterioles, and the capillary bed is perfused. The smooth muscle has constricted here. Smooth muscle has constricted here. So we're no longer perfusing the capillary bed, and now we just have a straight arteriovenous shunt or an arteriovenous anastomosis, because the blood flow, rather than perfusing the capillary bed, has gone straight through from our arteriole to our venual, and the capillary bed is not being perfused. Another example of this would be if you if this is a capillary bed around an alveolus, okay, in the lung. An alveolus is where gas exchanges in the lung. And you had pneumonia, or you had a fluid collection in the alveolus, okay? You had a fluid collection in the alveolus, or you had pneumonia in that particular alveolus. There would be no, because you've got pneumonia in there, no air exchange is going on there because it's essentially obstructed. We're talking about a single alveolus. You've got millions of alveoli, but there's no air exchange going on there, so there's no reason to perfuse that area because there is no oxygen there. Okay, there's no oxygen there, and there's not the ability to load up on oxygen and unload CO2. So if you had an alveolus that was plugged either with pneumonia or with fluid or something like that, you had severe pulmonary edema, these meta-arterioles would have constricted, and that area would not be perfused for the purposes of ventilation, not for the purposes of keeping the lung alive. We have vessels to keep the lung alive. Okay, the alveolus would still be perfused because it needs blood supply. And so those are two examples now. And so we go from a pressure in the aorta, which actually has a systolic and a diastolic pressure, to pressure in the arteries, okay, and arterioles. Here's the artery pressure, arterial pressure, as we get out to smaller and smaller arteries, and we start getting into the arterioles. This differentiation between a systolic and a diastolic pressure, or a systolic, diastolic, and mean pressure starts to go away, and we only have one pressure. Okay, we only have our mean pressure because we don't really have that pulse any longer. We don't have that pulse projection coming out of the heart. We just have a continuous blood flow. Okay, continuous blood flow and a pressure that, as you see, starts getting lower and lower and lower and lower. And one of the things you really don't think about is that as you approach some of the bigger veins, the pressure gets lower and lower. Okay, so as you approach some of the really big veins, the pressure gets lower and lower. And pressure in the vena cava is not very high. Okay, as compared to the artery, the pressure in the vena cava is not very high. Capillaries functions distribute oxygenated blood to all cells. Every cell in our body requires oxygen to function. Okay, every cell in our body requires oxygen to function. So we've got to be able to do that. We certainly can't do that through our big elastic conducting arteries. They're too thick. Okay, we have to get down to the level of where our blood supply is going to have a single cell, a simple squamous epithelium, and a basement membrane. And that way we're going to be able to have exchange going on into the capillary bed. So it goes out of the vessel into the interstitial fluid. That is the fluid between the blood vessel and the cells, okay? Or you could call it extracellular fluid. It's the same thing. And then exchange, and remember, these blood vessels are literally laying on the top. There are microscopic differences between the distances between them. They're literally laying on top of one another, and that exchange is going to go on there. Smallest vessels with the thinnest walls, average length is 1 millimeter. So the capillaries themselves are not very long, near every cell in the body, but depends on the tissue they serve. Some tissues need more oxygen. All tissues need oxygen, okay? Some tissues need more oxygen. Low pressure, slow velocity of flow. Slow velocity of flow. The reason we want a slow flow, okay, the reason we want a slow flow is the fact that we need time for the exchange to occur. We mechanically, we have done as much as we can. We've got one cell layer thick with a basement membrane essentially holding that cell on, making that a vessel. We've got a simple squamous epithelium sitting on top of a basement membrane. That's the thickness of a capillary. It can't get any thinner. They can't take anything out, okay? So we need to slow the exchange down. And the way it happens there is because of the pressure and because of the magnitude of the surface area. Because magnitude of the surface area. The capillaries are the hugest in surface area vessels of the body. We have a low pressure and slow velocity of flow. And so nutrients and materials and gases are exchanged between the blood and the interstitial fluids. So things come out of the blood into the interstitial fluid intended for the cells. Waste products come out of the cells into the interstitial fluid, going to be picked up in the vessels. Perfect example is CO2, which is going to be transported to the lungs from a byproduct of cellular respiration, the breakdown of glucose in the presence of oxygen, which every cell does, is CO2 plus water, and we get ATP produced. Well, we need to move that CO2 out of the cells, and we have a number of other waste products. So remember that the capillary is very thin. A basement membrane with a single layer of endothelial cells, and those endothelial cells are simple squamous cells, which are very thin. Exchange of materials. We exchange nutrients, gases, and other small molecules across the capillary wall by diffusion. Remember, diffusion is just the movement of a substance from an area of high concentration to an area of lower concentration, down a concentration gradient to equilibrium until equilibrium is reached or as close to equilibrium as possible. Fluids also cross the vessel wall and forced out the capillary by pressure, by hydrostatic pressure. A lot of these capillaries at this level are very leaky, okay? The pressure inside, especially on the arterial side, is higher. The hydrostatic pressure is higher than it is on the venial side, arterial venules. And so the pressure forces the fluid out, and that's hydrostatic pressure. We'll go into this in a whole lot more detail in some later slides. And then we have interstitial hydrostatic pressure and colloidal osmotic pressure, which are opposite of hydrostatic pressure. Hydrostatic pressure is the pressure head inside the vessel having a tendency to push the fluid through a leaky membrane. Interstitial hydrostatic pressure is the fluid pressure in the fluid outside the blood vessel, which has a tendency to push back, against that fluid that's trying to be pushed out. And the colloidal osmotic pressure is the pressure generated inside the vessel by the large proteins and larger molecules that have water collected around them. And because they have water collected around them, they retain that water and don't want to give up that water, okay? So we have forces of hydrostatic pressure inside the blood vessel trying to push fluid out. We have pressure outside the blood vessel trying to push fluid in. And we have a colloidal osmotic pressure, which is related to the number of particles, that is holding the water tightly around the molecule and retains some of the water. And so these three forces are interacting. These are just types of capillaries. We have a continuous capillary with a 4 nanometer, okay? Nanometer, nanotechnology, 10 to the minus 9 meters, okay? So that would be 10 to the minus 6 is a million, so 10 to the minus 6, 10 to the minus 9 is a billion, so that would be 4 billionths of a meter. These have clefts in them. So clefts are just areas where things can move between. Fenestrations are holes. Fenestrations are holes here where things can move in between the capillary. They're 20 to 100 nanometer holes. We have sinusoids, which are essentially big holes. Okay, they're big holes. They are where it's sort of an in between where actually you have a blood vessel and don't have a blood vessel, for lack of a better term. It is where exchange can, it's where pooled blood can collect and exchange can occur. And they have incomplete basement membrane. We don't have a whole lot of them. We have some in the liver. Venules, joining of capillaries. So we have the capillary bed. We had the arterioles, went into the capillaries. We now have venules coming out, okay? So these capillaries have joined. We have deoxygenated blood now. They are thin wall, but relatively impermeable, okay? So we had a lot of permeability in the capillary, okay? A lot of permeability in the capillary bed. Now, as we come away, except for the venules that are just forming at the edge of the capillary bed, they are now relatively impermeable, okay? Except for the extremely small ones, which means it would be the ones very close to the capillary beds. Now they're going to be impermeable because we really, now we have deoxygenated blood. Now we have waste products loaded up in the venules that we got from the cells. We have CO2 now in the venules that we got from the cells. So that we need a whole lot of this exchange going on, okay? Because we want to carry this back to the heart and have it dispersed to the liver, to the kidneys, to the lungs, wherever it needs to go to get rid of it and get the blood deoxygenated again. So remember, the most porous area, and the reason it's porous, the reason it has holes in it, fenestrations, clefts, is that we need to have a change going on. Now so arterioles are not porous, venules are not porous, except for the smallest ones that are approaching the capillary beds, okay? Pressure still falling. So we have the capillaries, the pressure is falling. Now we're in the venules, okay? Now we're in the venules. This is blood pressure in millimeters of mercury. Now we're below 20 millimeters of mercury. Veins are just joining the venules, same layers as arteries. So we're back to the 3 layers. Remember, we started with 3 layers and actually had a vasovasorum because we needed a blood supply because the elastic arteries were so thick and some of the conducting arteries were so thick. We then went down to the capillaries, which had a single layer of cells in the basement membrane. Went to the venules. Now we're back. Back to the veins, and they are conducting vessels too. We had elastic arteries, muscular arteries, conducting arteries. Okay, now we got conducting vessels too. These are conducting blood back to the heart. That's the whole purpose of these. This is the system of conducting blood back to the heart. Larger lumen but thinner walls versus arteries. If you ever get to see a vein, veins are very thin walled. Veins are very thin walled and they easily tear. Okay, you can tear them. An artery, you can take a pair of dissecting scissors and literally lay the scissors on top and dissect around the artery. A vein, you can't do that because it's very easy to nick the vein and get a hole in the vein and have venous blood coming out. Blood reservoirs only partially filled. Remember, the pressure now is so low. The pressure now is so low that they actually have to rely on other mechanisms to get the blood back to the heart. Because when we have a pressure head like this, we're pushing blood out into a system. Now we got a pressure that's so low, and most of the time, with the exception of the upper extremities, we're going against gravity. So we're trying to get blood flow to go back to the heart in a very low pressure system that's expanding in size. So if you have a low pressure system that's expanding in size, then the pressure is going to go even further down. And we don't have that pulse to try to push this stuff back. So lowest pressure in the system is in the vein structure. We have a one-way valve, and you can think about this like the semilunar valves, okay? Like the aortic and pulmonic semilunar valves. Remember, we have two major types of valves in the heart. We have atrioventricular and atrioventricular between the atria and the ventricles, and we have the semilunar valves. We have a pulmonic and aortic. If I were you, I would be able to explain how those valves work, okay? Because they work entirely different. I would know when they open and when they close and what causes them to open and close, because you're probably going to see a short answer question on that. That's the advantage of being in the lecture. is I essentially tell you some of the questions that are coming up. I told you in chapter 17 and chapter 18. And now I'm telling you a short answer question that's coming up. So you're going to need to be able to explain the two different types of valves in the heart. They're essentially atrioventricular and semilunar, okay? And you're going to need to know how they work. Number one, you need to well, okay, what causes to open and what causes them to close, because it's an entirely different situation for both those different types of valves. So you need to be able to do that in a short answer question. And you need to be able not to copy and paste it from the internet, because you'll get a 0 automatically. I copy and paste your answer into Turnitin, our plagiarism software. It comes up plagiarized, you get a 0, no questions asked. No questions asked, you get a 0. You copy and paste it from the notes, directly from the notes, you get a 0. You can look at the notes and write down your own words. You got the notes right there. All right, so we have from the innermost layer, from intima layer, an outcropping, some flaps of some veins here, some flaps of some valves, okay? What happens is we have managed through a number of things, usually with muscular contraction, if this is in our legs. So we've got a vein in our legs, we're trying to get blood back to the heart. Well, we've got it up this far, okay? And the contraction's over. If we didn't have this valve that works a lot like the semilunar valves, then when the contraction was over, we would have lost that pressure head, because that pressure head's what pushing that blood. We'd lost that, and that blood comes flowing freely back. Blood comes flowing freely back. If we didn't have this valve that's going to slam shut because of the pressure of this venous column right here, then the blood's going to flow right back to the big toe, wherever it came from. Okay, so we have venous valves here, which are just an adaptation of part of the tunica intima to prevent backflow of blood. These are one-way valves. How do we get blood to return? Number one, we have a little bit of a pressure gradient, but not very much. A little bit of a pressure gradient, but not very much. Skeletal muscle. So here we're talking about the gastrocnemius muscles, okay, or it could be the biceps muscles, it could be something. But you can see here, when the blood contracts, when the muscles contract, they're going to squeeze that blood upwards. So they're going to squeeze it up in this general direction towards the heart. If we're talking about the upper and lower extremities, squeezing it up towards the heart. So we're going to push this column of blood up this way in the vein. And as this muscle relaxes, then when this blood's going to come back, these valves right here on the vein are going to close. And these then will have another contraction of this muscle, you know, because even if we're setting, like all of you are setting, unless you have you're standing up and watching this, even as you're setting, you're moving. You know, I'm moving my legs around, okay, and we're pushing this blood up. This is the reason that they recommend that if you're on an airplane and you're taking a long flight, not a short flight, but a long flight, that you get up and walk up and down the aisles, okay? Because if you don't, you're not pushing this blood, you have venous stasis, okay? You have venous stasis, then the potential exists for a blood clot to form. And if you get a blood clot to form and you flow it and it throws it to your lungs, you get a pulmonary embolus, you actually could die in the plane, and very little they could do for you, okay? So they recommend if you're going to be on a long flight, you might wear a support hose, and you certainly get up every hour, every 2 hours, or you do some kind of leg exercises. For patients in the operating room, they have compression, pneumatic compression things they'll put on people's extremities that go up and downwards during long procedure. And a number of other things they do. I haven't been in the operating room for a long time, over 20 plus years. Those are the things that we used to do. So skeletal muscle pump, we also have a respiratory pump. Remember, as we inhale, okay, actually as we drop the diaphragm, we increase the volume in our thoracic cage. As we increase the volume in our thoracic cage, if we increase the volume, we decrease pressure. And we'll learn these gas laws when we get to the respiratory chapter, which will be in the next group, okay? You know, the next group will be lymphatics, immune system, and respiratory. We'll learn these gas laws. But if you increase the volume, just like if you had a 15-inch wheel and had 32 pounds per square inch, and you took that air and put it into a 30-inch wheel, obviously the pressure would be much lower than it would be in that whatever we started with before. Same way in the respiratory thing, you drop your diaphragm. Your diaphragm sits at the junction of the thoracic and abdominal cage. When it contracts, it goes down. You increase the volume, decrease the respiratory pressure, and so this decreases pressure around the heart. And we have decreased pressure. We have the potential for blood flow movement. Smooth muscle contraction of the veins, sympathetic. So we can have also with sympathetic stimulation, we can have smooth muscle contraction in the veins. Sympathetic stimulation, smooth muscle contraction, because remember with sympathetic, that's our fight or flight reflex. I always talk about the T-Rex chasing me. What do I need with the T-Rex chasing me? I don't need to be digesting the meal. I need to have my pupils wide open. I need to have blood. I need to have blood flow to my muscles. I need to have blood flow to my heart. Okay. I don't need my GI system going. I don't need my kidney system going. I just need to have what I need. And so that's the way I think about the sympathetic system. What do I need going in my body when I have, when the T-Rex is chasing me? Collateral circulation. We have a lot of collateral circulation. As you can see here, okay, if this would be an arteriole, and these are meta-arterioles because they have these sphincters here. And say we got a clot right here in this arteriole. Say we got a clot right here in this arteriole, or a clot right here in this arteriole. We have collateral circulation. We have collateral circulation. We could still shunt blood around through here. Okay, so we have a lot of collateral circulation in the capillary beds, and we have certain areas of collateral circulation in some joints, and the circle of Willis, which we don't talk about very much about in anatomy and physiology. One is actually a circle that brings the most of the major blood vessels that are coming into the brain into a circle, so that if you have an obstruction of one of the other blood vessels, because this is a circle, you can have blood flow to that part of the brain that would normally get its direct blood supply from a feeding vessel, because of the circle of Willis. So we have collateral blood supply in a number of places to prevent complete cessation of blood flow. This is one of the reasons, is formulated as one of the reasons why you want to exercise. Of course, when you exercise, obviously you're exercising your body, but you're also exercising your heart. As you exercise, you have an increased need for oxygen. And because you increase need for oxygen, one of the things that you do is develop more collateral circulation. And collateral circulation in the heart would be very good, because if you happen to have ischemia or an infarction and you had collateral circulation, hopefully you would have less necrosis. Number one, hopefully you would survive the event. And number two, you'd have less necrosis in that particular area. Portal system. We have a portal system that essentially has two capillary beds. Normally we think about having a capillary bed to perfuse the alveolus, a capillary bed to perfuse the kidneys, a capillary bed to perfuse something else, okay? But sometimes we need to have two capillary beds in the system, rather than just an artery and an arteriole to capillary to venule to the vein, okay? And one of these, an example, when we get to the GI system, we will talk about this more extensively, and this is the hepatic portal situation, okay? We collect nutrients from the intestine, not primarily the small intestine, but we collect nutrients from the small intestine by way of a capillary bed. We then transport that nutrients to the liver, because we're gonna take those nutrients, we're gonna absorb those nutrients, we're gonna absorb, we ate a piece of steak, we broke it down into the component amino acids. We're not gonna use the protein of another animal. We break that down into component amino acids, the 20 amino acids, we're gonna use the amino acids. Well, those are gonna be absorbed. We eat complex carbohydrates, no matter what it is, okay? Whether it be starch out of plants that we can digest or some other complex carbohydrates, we break those down into monosaccharides. We break the lipids down, and we actually, remember, we're eating DNA too, okay? We're eating animal DNA, okay? So we're going to break that down in components. We're going to absorb all that. Well, a lot of stuff in the body is assembled and categorized and sent to different places, and that decision-making process is done in the liver. Okay, that decision-making process is done in the liver. So we're going to collect that material by way of a capillary bed around the intestine. Then we're going to transport it by way, we're going to go from the capillary to the venule to the vein. We're going to transport it by way of the portal vein, and we're not going to go back to the heart. We're going to go directly to the liver. Okay, we're going to go directly to the livers. So we're going to transfer this material to the liver and allow it to pick and choose the nutrients that it needs, and maybe store some iron, maybe send some other iron on, maybe discharge some waste products in the form of bile into the small intestine. So we're going to transport this by way of the hepatic portal system back to the liver, and we're going to go into a capillary bed in the liver. Okay, because we got to have exchange occur. We've got this system now. We got a big, the portal vein's a big vein. Okay, it's not as big as the vena cava, but it's a big vein. We're going to transport it back to the liver and have a second capillary bed where exchange is going to occur, and a lot of those, some of the nutrients are going to stay in the vessels, but a lot of nutrients are going to go out. Okay, and this is not a very good schematic, but what this represents is we have small intestine absorbed proteins, nutrients travel by way of hepatic portal vein, and this is the hepatic portal vein here that actually goes off the GI system to the liver, and then the liver sits on top of the vena cava. So the venous system from the liver, so you've transported venous blood not back to the heart, but directly to the liver. And the venous blood from the liver is going to drain right to the vena cava, because the liver sits right on top of the vena cava, and there's about a 1 centimeter big vessel. It's a huge vessel, except it's only about 1 centimeter long, and it's the drainage for the liver into the vena cava. Physiology of circulation: blood flow, blood pressure, and resistance. Okay, definition terms: blood flow, volume of blood flow that flows through tissue at a given time. Usually talk about, you might talk about milliliters of perfusion per gram of tissue. This is cardiac output. These are obviously some of the equations you're going to need to know. You might get a problem on a multiple choice question about calculating cardiac output. It's just stroke volume. We decided was in diastolic volume minus in systolic volume, and we had 120 minus, and we came out with 70 as our stroke volume, because we had 50 milliliters of blood left in the heart. But that can be calculated. You could be given another system, but you know how to figure that out, because if they tell you how much blood was in the ventricle to start with and how much blood was left, you know what the stroke volume is, and you just multiply that by the heart rate. Okay. How it's distributed is based on pressure differences, driving forces, high to low, and resistance in specific vessels. Okay. Vessels, obviously, if they're constricted down, have more resistance. If they're completely restricted down, have a lot of resistance. You're not going to get any flow there. Blood pressure, force per unit area. Pressure, a physics definition, is force divided by area. Force divided by unit area. And so when we measure pressure, we're actually measuring these pulses. We're measuring these pulses against the blood vessels. Systolic pressure is the highest pressure attained in systole. Remember, systole is ventricular contraction. That's the work phase of when the heart beats. That's when the ventricles are contracted. The atria have a systole. Okay, the atria contract, but the atria, they're very thin wall. Their contraction although we can see it on the EK, or we can see the depolarization. We don't see when we look at EKG, we're not seeing contraction. What we're seeing is depolarization. Okay, we see the electrical signals between SA nodes, AB nodes, and those types of things. That's what we're seeing, and we interpret that as what's going on in the heart. So systole is ventricular contraction. That's when the ventricles are contracting and obtaining the highest pressure. Remember, we have a first portion of the ventricles as the ventricle is increasing pressure. The pressure gets to be so great that the AV valve shut. Okay, and so we continue to keep the same volume as the ventricles contract. The pressure and all valves are shut, so the pressure increases. We continue to crack. We continue to make the volume decrease with the same amount. The volume of the ventricle decreases in size while the volume of the blood remains constant. So the pressure increases until at such point that the pressure inside the ventricle is greater than the pressure outside, whether it be the pulmonary artery or whether it be the aorta. At that point is when the pulmonic valves open up. Okay, at that point is when the semilunar valves open up, whether it be the pulmonary or aorta. And so we have systolic pressure, which is the highest pressure during systole, and diastolic pressure is the lowest pressure during diastole. Of the two, which is most important is diastole, because that's the heart at rest. And so the doctor is more concerned with the bottom number. Now, obviously, they're concerned with the top number too, but the bottom number is the one when you're looking at hypertension they're most concerned with. And I told you I have hypertension. I'm on 2 blood pressure medications. The criteria keeps changing. It used to be the lactate diastolic would be below 90, and now it's 85. At least it needs to be below 85, and they're constantly monitoring your weight and your medications. And my blood pressure is entirely weight related because I used to be on 3 medicines when I was close to 300, and now I'm 220 and down to 2. Probably if I got below 200 pounds, I'd be down to 1. Diastolic pressure, lowest pressure during diastole, pulses in arteries, blood intermittently during ventricular contraction. Why is it intermittently? Because at some point the ventricles are open, at some point the ventricles are closed. So it's intermittently. So the ventricles contract intermittently. When they send the highest pressure is when the ventricles are contracting, and example is the aortic valves open and the blood's being pulsed out of that. Until at some point the pressure inside the left ventricle is less than the pressure inside the aorta, at which point the aortic pulmonic valve shuts, the aortic semilunar valve shuts. And remember, when the aortic semilunar valve shuts, that your orifices for your coronary arteries are right above the aortic semilunar valves. So when the valves are open, they're not being perfused. They only perfuse during diastole. Expansion recoil of arteries, because now you have a pulse. And so that expansion recoil of arteries occur. How does the pulse systolic pressure can be measured? Normal 120 millimeters, okay? Lowest point between the ventricular contraction, diastole 70-80. So you hear 120/80 as an average normal blood pressure, okay? Force of the left ventricle, diastolic pressure represents the condition of the peripheral vessels, because obviously the left ventricle is the one that is pushing the blood flow out into where we're measuring the blood pressure. If you have a catheterization, okay, if you have a catheterization, obviously they measure the cardiac catheterization, they measure the pressures in the pulmonary arteries and in the aorta and in all the chambers of the heart, and the right and left atrium, right and left ventricle. So they have more information than we get from just taking the blood pressure. Pulse pressure is the difference between the systolic and diastolic pressure. So if we had a pressure of 120/80, we'd have 120 minus 80, that'd be 40. Difference is what keeps the blood moving, high to low. Taking pulse involves pushing on the vessel enough to feel the systolic pressure. Number of places to do pressure: posterior tibial and dorsalis pedis in the feet. I was a chief resident, and I had a attending on the medicine service call me and say, hey, you need to come up and look at the consultation your intern written. And sure enough, I went up there, and the intern said that patient had 4+ posterior tibial and dorsalis pes falces, and you look, they had bilateral above knee amputation. So that just showed they didn't do a physical exam. And so if you're going to report something, always make sure that they've got the extremities. You're going to get tripped up. Okay, you're going to get tripped up, but don't make the same mistake that intern who only stayed their first year there didn't go to their second year. But there's a number of places you can check the pulse. Okay, and so you probably already know a lot of these because you use them either when you're out exercising, you fill up your pulse up in the side of your forehead, or you can palpate your carotid pulse, your radial pulse. Arterial pressure is different than pulse pressure. Okay, it's the average pressure in the arteries. Okay, and it takes a number of things into account. Systole lasts longer than diastole. Excuse me. The rest phase, diastolic phase, is longer than systolic phase. Blood flows from high-low pressure, important in maintaining steady blood flow. And here's an equation. You add your diastolic blood pressure plus 1/3 of your systolic minus your diastolic. So if your diastolic blood pressure is 80 and your systolic is 120 minus 80, that'll give you 40. And 1/3 of 40 is 13. So 13 plus 80 is 93. And I did that in my head, okay? Or you can do it by cardiac output times resistance, but most people don't know you don't have the resistance in the system. So this is a good ballpark figure to use if they ask you for the mean arterial blood pressure. Pulse pressure is just systolic minus diastolic. Mean arterial blood pressure is your diastolic blood pressure, which is your bottom number, plus 1/3 the difference between your systolic minus diastolic. Systolic minus diastolic and pulse pressure. So you just add those together and that gives your mean blood pressure. Factors increase blood pressure, increase stroke volume. Increased stroke volume is how much blood is being ejected by the heart. And increase in the blood volume, okay? In other words, if you have polycythemia, you have a lot of red blood cells, or you have a lot of fluid, that's increase in blood volume, or an increase in the heart rate, okay? You want to see your blood pressure go up, just get into a panic attack and measure your blood pressure, okay? And increase in your resistance. If your resistance is clamped down, okay, then that's going to increase your blood pressure. Hopefully that's intact in each and every one of you, because when we sit down for a long period and stand up, we increase the resistance by clamping down on some of our venous system so that we can maintain blood pressure in our head till we get used to standing up, okay? We reiterate the formula again. This requires resistance, and we just don't have that number. What's resistance? Friction between the blood and the walls of the blood vessels. Friction between the blood. We would like everything to be smooth, but as you know, everything's not 100% efficient. We have vessels branching off. We have vessels coming back in. So we have potentials for turbulence. We also have vessels being vasodilated, vasoconstricted, depending on blood viscosity, the ratio of the red blood cells to plasma. Okay, if we have polycythemia, which you talked about in chapter 13, that's an increased red blood cell mass. We also, if we're dehydrated, we're losing volume. So that's going to increase resistance. If we have anemia means a lack of red blood cells. Okay, we're going to decrease the resistance, decrease the blood viscosity. These are things. Blood vessel length. You have the two lab modules are looking at radius and blood vessel length, I believe. This is a fascinating thing. I've got to look this up, see if this is true. Okay. If you are obese, okay, in other words, if you are above 30 in a body mass index, okay, you have 650 kilograms of blood vessels for every kilogram of fat. Well, a kilogram is 2.2 pounds, so you really need to know that. Why do you need to know that? If you read any medical journal outside of the United States, it's going to be in kilograms, okay? It's going to be in kilograms. The Jaguars, you know, they're not going this year, but every year that they go over to England and they have to find out if their bed's going to hold up one of their linemen, okay? They need, you know, or it's one of those tall people going to be able to walk through the door. they need to be able to utilize the metric system. Now, granted, you've got apps on your phones to figure out all this, but a lot of the medications is in milligrams per kilogram, so you're going to need to know how to convert between kilograms and pounds, and 2.2 kilograms. So for every 2.2 pounds of fat you have, it says you have an extra 650 kilometers of blood vessels. Okay, well, 1.678 or something like that. It's 1 point something kilometer is a mile. Okay, so that's a lot of extra blood vessels there. So that could be why people who are fat experience cardiac strain, because of the blood vessel length. Blood flow is fastest in higher pressure, large diameter arteries. Blood flow is slowest in lower pressure, small diameter arteries, and it's because of the resistance is related to the fourth power of the radius. You'll see this on that lab you're doing. It's related to the fourth power of the radius. I initially had 3 labs, and I took one of the labs out because I thought that's just too many labs to be doing and having a test too. So there was another really good lab that I really would like. Had it been any other time other than the week we're having a test, I'd have left it in, but because we're having a test, I only left the 2 labs in. And it's related to the fourth power. And so if you double the radius, in other words, if you go from 1 to 2, if you use the fourth power, then you've got 1/16 the resistance. Blood picks up speed in the venules and veins as lower pressure is compensated by the larger size of the vessels. And this shows the total area. Remember, I said the capillary bed has the largest amount of total surface area of the vasculature. Okay, largest amount of surface area of the vasculature, and the velocity of blood flow, which starts out, velocity is in centimeters per second. Okay, remember 2.5, so 4 centimeters is 1 inch. You ought to get your handle on a couple of maybe 5-10 metric measurements that you just remember, and then with those you can convert anything. Okay, you can convert anything using if you remember, about 5 or 10 metric measurements. But this is blood flow in centimeters per second. Okay, and so you can see blood flow decreases as we go from aorta to arteries to arterioles down to capillaries. It's the lowest in the capillaries, which has the highest surface area. Okay, and that is actually beneficial to us because that's where as I started the lecture out, that's where the work goes, where we do all the exchange, where the cells get nutrients and oxygen and things like that, and amino acids and hormones and all the stuff that's made and transported, and they dump off waste and CO2 and stuff. We then have blood flow, velocity of blood flow increase, okay, as the total surface area decreases. Remember, we still have a low pressure system. Remember when we looked at the pressure curve continues to go down despite the increasing size of the vessels, but the blood flow, because it's a relationship of the fourth power of the radius of the vessel, is going to increase as we get into bigger and bigger veins. Maintaining blood pressure. We got short-term mechanisms to maintain blood pressure. We have vasomotor centers in the medulla. Okay. Remember, if you get 3 or 4 years from now, when you're sitting there and taking your boards, or 5 years, or however long it is, or you're taking a recertification exam and they throw one of these questions in from you, you're taking a recertification in cosmetic plastic surgery, and they throw a question, how's the vasomotor center of the brain for blood pressure? And you remember that Dr. Phillips said, if there's a chance that they got medulla or pons there, and if they got them both in the answer, pick that. If they don't, pick the medulla. Okay. And I tried to give you little hints like that because I can't remember all this stuff, but that's one of the little hints. So we got baroreceptor. Baro means pressure. Barometer measures pressure. Okay. When we start getting storms and hurricanes, the weatherman's talking about the barometric pressure. Is it dropping? That's always a bad sign during a hurricane. It's the barometric pressure's dropping. Okay. Those sense arterial pressure in the carotids and in the aorta. We'll see a lot of this have receptors in the carotids and the aorta. Okay. They're going to sense pressure changes. Okay. they have a constant input into the medulla, okay? Higher than normal pressure stretches the baroreceptors, leading to increased signals to the cardiovascular center, okay? So the blood pressure has gone up. It stretches those receptors. These are pressure receptors. We then, what are we going to do? The pressure's going up. How are we going to get the pressure to go down? We're going to increase the parasympathetic nervous system and decrease the sympathetic nervous system, okay? Our pressure is going to go up when the T-Rex is chasing us. That's sympathetic, fight or flight. Our pressure is going to go down after our buddies have killed the T-Rex and we're all sitting around the campfire eating T-Rex meat, okay? We're going to have a good time. Our pressure is going to go down. If we need pressure to go down, we've got to have increased parasympathetic stimulation, parasympathetic nervous system stimulation, and decreased sympathetic nervous system stimulation, decrease heart rate, strength of contraction, decrease activity of the sympathetic nervous system, leading to vasodilatation. If we have vasoconstriction, that's going to increase our pressure even further. So we're going to have vasodilatation. We're going to decrease the resistance, and then we're going to lower the cardiac output. Or if the baroreceptors sense falling blood pressure, okay, then those signals that they're normally sending. See, there's a normal signal. It's signaling right now, me and you, to the medulla. Okay, normal pressure, normal pressure, normal pressure. Unless you're sitting here and say, hey, is he ever going to end and talk about the test and your blood pressure starts going up, going up, going up. Or if you drank 4 cups of coffee and you're saying, do I need to go or should I stay here and listen? Your blood pressure is going up, okay? Well, if it starts dropping, that baseline signal we're sending to the medulla saying, okay, the pressure's okay. We increase the signal if the pressure starts going up. Now those signals are not going nearly as much as they were going a while ago. The medulla says, based on the baroreceptor information, okay, based on baroreceptor information, our blood pressure is going to go down. What are we going to do? We're going to do the opposite of what we did. We're going to decrease the parasympathetic nervous system stimulation and increase the sympathetic nervous system stimulation. Our adrenal gland is going to secrete epinephrine and norepinephrine. We're going to increase the heart rate and the strength of contraction. We're going to have a higher cardiac output, and that's going to lead to arterial vasoconstriction and increased resistance, and our blood pressure is going to go up. So these are baroreceptors. All they do is measure pressure. Where are they located? Aortic arch and the carotid. Chemo-initiated reflexes, sense low oxygen, low pH, and high CO2, carotid bodies and aortic bodies. So where are they at? Carotids and the aorta, okay? Cause increased sympathetic output and vasoconstriction to speed blood return to the heart and the lungs. So if these chemoreceptors sense low pH and high CO2, because remember when we looked at if we combine CO2 plus water, that gives us carbonic acid, which breaks up into a hydrogen ion and a bicarbonate ion. If we have an increased CO2, that shifts the equation to the right. And if the equation shifts to the right, we have increased hydrogen ion concentration, and that lowers the pH. So what you want to do, okay, you need to do something that's going to get the blood back to the heart and lungs and get that CO2 blown off. So if you blow the CO2 off, you can raise the pH up. So this is a chemoreceptor. We had baroreceptors that measured pressure, blood pressure in the carotid and in the aorta. We have chemoreceptors that measure oxygen concentration, okay, or sense oxygen concentration by measuring low pH and high CO2. They're in the carotid and the aorta, okay. We have hormonal control, angiotensin 2, okay, vasoconstrictor. You need ACE, which so there's angiotensin 1. It's going to be converted into angiotensin 2, and we need ACE angiotensin converting enzyme to convert this angiotensin 1 into angiotensin 2 so it can be vasoconstrictor. One of the most common blood pressure medicines there is an ACE inhibitor. I take an ACE inhibitor. So it inhibits the conversion of angiotensin 1 to angiotensin 2, so that this vasoconstriction doesn't occur and lowers my blood pressure. You will, if you're going to the medical field, you will meet a lot of patients on ACE inhibitors. It's one of the most common, but besides diuretics, besides just something to increase the exit of fluid from the body, is one of the most common blood pressure medicines used, and it's called an ACE inhibitor. And now you know where it works. There's an enzyme called angiotensin 1 that needs to be converted to angiotensin 2 to cause vasoconstriction. We have to have this enzyme and ACE, which is angiotensin converted enzyme. We have a blood pressure medicine that blocks that enzyme and lowers blood pressure. Okay. We have anti-diuretic hormone. Okay. Diuresis is a losing of fluid. If you have a major diuresis, okay, you take a water pill to drive water out of your body. Bodybuilders take a water pill when they're trying to get cut, you're ready for the competition. They're trying to get the water out of their body so that their muscles can be seen. Okay. We have a hormone which is called ADH, which is an anti-diuretic hormone. Okay. We have an anti-diuretic hormone which will retain water. Retains water, it's a vasoconstrictor. We have epinephrine and norepinephrine. Okay. Vasoconstriction in most vessels, vasodilatation in the heart and skeletal muscles. Epinephrine and norepinephrine are released during sympathetic stimulation, during fight or flight reflex. They are released by the adrenal gland. We need, when that T-Rex is chasing us, we need blood flow to the heart and the skeletal muscle. We don't need blood flow to most other vessels. So if you can get to where you can think about what, in whatever method, I just use the T-Rex analogy, okay? You can think about anything else you want to, what you need to have working if you're in a fight or flight reflex. And you can just work through your way through a lot of these questions without really knowing the answers, just by thinking through the things. And that is, ladies and gentlemen, that is what your employer 5, 10, 20 years from now is going to pay you for. They have artificial intelligence now that can come up with a list of things. They don't need somebody that knows a list of things. They need problem solvers, okay? So you need to develop a thinking modality that allows you to be a problem solver. They don't need somebody to come up with a list. They don't need somebody to come with a differential diagnosis. They can put the patient's symptoms into a computer and have a bunch of things spit out and order the lab tests automatically. What they need are problem solvers. What can you do if the information that you get is not consistent with the diagnosis? Or what can you figure out about what's going on? So I realize that you just seem like you just learning fact after fact after fact, but I try to impart a little bit of wisdom. Back in the day, that's all you needed was a bunch of facts and be able to pull them on your head. But that's not the way it is these days. And you're well aware of that. Everybody's well aware of that. So just keep that in the back of your mind. Become a problem solver. When you are a problem solver, you add value to yourself and value to your employer. And one of the ways I try to do that is trying to think about this being chased by a T-Rex and not being chased by a T-Rex. So epinephrine, norepinephrine, I don't know what they do, but I know epinephrine, norepinephrine. I know when I get scared, my heart starts beating fast because I get a lot of epinephrine in my system, okay? Well, epinephrine is going to cause, and I know I need blood to my heart and my skeletal muscles because they're going to hit the room for the T-Rex. And I know I don't need blood to my kidneys or my GI system as much. Nicotine will also cause vasoconstriction by directly stimulating sympathetic neurons and promoting release of this, epinephrine and norepinephrine. Anti-natriuretic factor is released by the atria, okay? It's secreted by some atrial cells when blood volume pressure gets too high. It's called ANF. Antagonizes aldosterone, causing kidneys to aldosterone. When we get to the kidney chapter, what aldosterone does is preserve sodium, okay? So we don't excrete sodium, okay? We don't get rid of sodium. Well, what ANF does, it antagonizes, so it works against aldosterone, and it wants to excrete sodium. And because sodium is a charged molecule, it's a charged electrolyte, has a positive charge, it is surrounded by water. Remember, water is polar, okay? Water has a positive side and a negative side. partial polarity. So if you get rid of a sodium, if you put a sodium in the urine, you're going to have a bunch of water follow that. Okay, you're going to have a bunch of water follow that, and that way you're going to lower the pressure because you're going to reduce volume. It also causes vasodilatation. So this is just another hormone. Long-term mechanisms, because those are the short-term things that can work relatively short time. Regulation of volume, renal regulation, renin-angiotensin mechanism, angiotensin 1, ADH to reabsorb water. We talked about that. Aldosterone to absorb sodium. If you want to increase your volume, you hold on to sodium because sodium is surrounded by water. Then the water comes with the sodium, so obviously you increase volume. You also activate the thirst mechanism. Kidneys secrete more or less water if necessary without harmonium fluids by increase or decreasing speed of filtration. So when we get to the renal chapter, we'll learn a lot of this stuff. This is just a lot of this summary. Autoregulation control locally dependent on tissue needs. Metabolic control, declining O2 levels, increased rare products will cause vasodilatation. Can also be indirect release of nitric oxide. Nitric oxide, if you're into muscle fitness or into nutrition, if you've seen the Super Beet commercial, that little jar of stuff, it's about $140 for concentrate Super Beets. The big thing in it is release nitrous oxide. If you're into fitness, you will go in and buy those jars of stuff. One of the things you can buy is something that supposedly increases the release of nitrous oxide. This is how a lot of the medications for ED work. By releasing nitrous oxide, causes vasodilatation, okay? And this is one way of metabolic control, but they are products. I don't know how well they work, Super Beets, but release nitrous oxide provides vasodilatation. So obviously, if you can provide vasodilatation to your muscles, you can work harder your muscles. You can provide vasodilatation to your GI system. You can have better digestion. So there's a lot of beneficial things. It also causes vasodilatation inside the skull. So if you have a weakened blood vessel, that probably is not one of the things you want to dilate up, if possible. Okay. Opening and closing precapillary sphincters. These are things that we can do to increase and decrease blood pressure. Myogenic response. Passive stretching causes increased contraction to slow blood flow. These are, this is a laundry list of stuff. We're going over it. Most of the stuff we'll cover again in great detail. So just use this as a laundry list. Obviously, you have these as notes. This is not very much, I'm interested in the baroreceptors, the chemoreceptors, and those type of things. This primarily is a laundry list. So probably won't see any of this stuff on the exam. If you did, it's just right. It'll be right out of the notes. Reduce stretches promotes vasodilatation to increase blood flow into the tissue. So these are just local responses. And then lastly, you can grow new blood vessels. Okay, blood flow in special areas, skeletal muscle. Exercise is strenuous because the increase of blood flow into the muscle. Autoregulatory stimulus is CO2 builds up, O2 decreases. That would increase the blood flow in. The brain, we actually don't increase and decrease blood flow. We keep blood flow going into the brain it's constant and consistent. So very little, but brain sensitive to changes in CO2 levels. Low pH causes vasodilatation, but like I say, there's not very much change in the blood flow. We do things to preserve blood flow to the brain, but the blood flow to the brain is pretty constant. That's why we have those. That's why the carotids are elastic arteries to take that pulse pressure from, because the carotid is not very far away from the heart. We want to dampen that pulse pressure from the heart. Lungs, we have autoregulatory stimulus, okay? And I actually talked about this. If we have low O2 in an area of the lungs, we get vasoconstriction, okay? Because we don't want to have capillary exchange where there's no oxygen. So if we have obstruction by pneumonia or obstruction by fluid, we're going to have vasoconstriction of the capillary beds because we don't want to perfuse that area because we don't have any capability of perfusing, okay? Because the alveolus is obstructed, so there's going to be no gas exchange. Consequently, if we have areas with hyperperfusion, then we're going to dilate the vessels in that area. Okay, homeostatic imbalances, we can have an aneurysm. These are the different type of aneurysms. Sometimes the that's my sip of Coca-Cola. If you have a known patient with an aneurysm and they have a GI bleed, that patient needs to be evaluated expeditiously. The reason being is sometimes these aneurysms will fuse with the GI system and actually rupture into the GI system. So if you have like say a patient with a known aneurysm or an older patient with potential for an aneurysm who has cardiovascular disease, you need to evaluate them expeditiously to make sure that they don't have an aneurysm that's not ruptured into the GI system. Because you can imagine with a ruptured aortic aneurysm, these people need to have some expeditious treatment. Leaking aneurysm, you need to have expeditious treatment, but if it ruptures, you gotta have treatment fairly quickly, or you're going to bleed out. Varicose veins, if the veins are competent, obviously, the blood's going up this way. When the compression of the muscle stops, the valves close. Whereas if the valves are incompetent, this is what happens. The blood flow comes back, the veins dilate. Prolonged standing, pregnancy, and hereditary. A lot of people get them. There's all kinds of different treatments for them. Orthostatic hypotension, decreasing blood pressure when one stands up. That's sluggish barrel reflexes. Atherosclerosis, hardening the arteries. Older people may have high blood pressure that you're not going to be able to get them down to 120/80 because of their hardening of their arteries. It's so hard. The arteries are so hard that if you get them down to 120/80 and they live at 160 or 180/100, they're not going to be perfusing their head. So you have to be careful about that. There again, that's outside of my field. But if you got bad atherosclerosis, you got to make sure that they are perfusing. Capillary dynamics, this is the last big topic. Simple diffusion. We're going to take a short 5-minute, or we're going to take a break till 10:30. So we're going to take about a 7-minute break. We'll be right back. Anybody got any questions? I'm back now. I had to run and get me a piece of candy. Anybody have any questions? You have to hold the space bar down. All right, let me see. That I don't know. I answered that question for an email, I think, for you. I don't know the difference between 75 and 125. My guess is that the 125 has the ebook. The 75 just has access to the Pearson assignments. That would be my guess. I don't specifically know. That you could actually send a thing to customer service and ask them, they could tell you. This is a long lecture. There's over 200 slides, I believe. So you might want to contact Pearson and ask them. You can contact customer service and ask Pearson, okay? Because you're buying the service through Pearson. So if you purchased a 75 in last semester and that was fine, if you had a physical book, and I would assume 75 this semester would be fine too. That would just give you access to the Pearson assignments and not to the ebook. That's the best I can tell you. You're going to have, I don't know any more than that. You will have to contact Pearson. Contact their customer service department and ask them. The previous lectures, at some point I'll move them over to YouTube. For right now, the links are still active. They're still working. The problem with storage, I bought a subscription to Zoom that gave me a gigabyte of storage in the cloud. Well, the first lecture for each class took up 92-93% of the gigabyte of storage. So then I tried storing them on Canvas, but unfortunately Canvas itself only gives you a gigabyte of storage per whole class. Not all the classes, but just per class. That would include your slides and everything. So I contacted my mentor, Dr. Oler, and she gave me a couple of solutions. The easiest solution is to post them on Facebook, post them on YouTube, and to then put an embedded link back to the YouTube thing. And I did that for the third lecture in my Anatomy and Physiology 1 class on Tuesday night. It took me a couple of days to figure out. You know, a lot of this technology is new to me because I've never posted YouTube videos before, okay? I am not like you, okay? All you people grew up with computers, okay? I went to college with a slide rule. We did not have calculators. We didn't have anything, okay? I did not grow up with a computer. I'm almost 70 years old. I learned all this stuff by going to the internet and watching videos. I learned all this stuff by going to the internet and watching videos. If I don't know how to if I don't know how to upload something to Canvas, I go to Google. I type in, how do I upload X, Y, and Z to Canvas? I then get 4 or 5 videos to watch, and then I watch the videos, and then I do what they say in the videos, and then that works. That is what I'm talking about, it being a problem solver, okay? You need to develop a skill. You need to develop a skill where you can figure out things for yourself, Now, I'm here to help you, okay? But you need, but when you get working, you're not going to be able to pick up the phone every 2 minutes and call somebody. You need to be able to skill, and you have the world's resources at your fingertips now.
Okay.
To find out how to do something, okay? You have world's resources at your fingertips. I use it on a daily basis to learn how to do this technology. I had no idea how to load a YouTube video. I had No idea how to edit a video. I've never done any of that stuff in my life. Never done any of it. But I learned how to do it. Okay. And if I can do it at almost 70 years old, you can do it too. All right, so we'll get back with the lecture. We're going to talk about capillary exchange. What actually happens at the capillary level? What actually happens at the capillary level? First thing, you got simple diffusion. You got all these holes, all these clefts, okay? And things will just go out, okay? Diffusion, go down a concentration gradient from an area of higher concentration to an area of lower concentration until equilibrium is reached, if the potential for equilibrium is reached, okay? Fenestrations, intercellular clefts, O2, CO2, glucose, amino acids, hormones, all these, gases, and small molecules can go through. Glucose is small, amino acids are small, most of the hormones are small. All plasma solute, okay, solute. You have solvent and solute solution, okay. Most of the small molecules come out. The big things that don't go out are proteins, okay. The only ones where proteins can go out are in the liver, sinusoids, liver sinuses. Remember I told you the liver has sinuses, okay? These are the only, one of the few places that the big proteins, the big molecules can go out, okay? Otherwise, if the level of the capillary exchange, the big proteins that are inside the cell, like albumin is going to remain inside, okay? You start dumping a lot of protein, into your urine, then you probably got something wrong with your kidneys, because normally you shouldn't be dumping a lot of protein, because proteins can't get out of these capillary exchanges if they're in the kidneys, okay? Brain capillaries are non-fenestrated. We actually have a blood-brain barrier. Why is this important? Because number one, if you're trying to treat an infection, okay, if you're trying to treat an infection in the brain, you need an antibiotic that's going to cross the blood-brain barrier. If it doesn't cross the blood-brain barrier, it's not going to be effective. So we have the capillaries in the brain have very tight junctions. The blood-brain barrier is one of the places that are walled off, and when certain things can get through, obviously oxygen and CO2, medications, anesthesia can get through, alcohol can get through, nicotine can get through. So there's good and bad things that can get through, okay? But not everything can get through this barrier. So we don't have as much fenestration in the brain. Filtration and reabsorption. What happens at the arterial end of the capillary and what happens at the venous end of the capillary? This is very important, okay? You're going to see some variation of this as a short answer question in your exam, which is going to open up on Tuesday. Remember, it's not going to open on Monday. It's not going to open up on Monday. It's going to open on Tuesday. Bulk fluids move across membranes along with nutrients and gases. So fluid's going to move, nutrients and gases going to move, forced out of the clefts at the arterial ends. You got a pressure head there. You got all these openings to push fluid out. Stuff's going to be pushed out. Okay, but everything can't get pushed out, because otherwise your entire body would swell. Okay, you've got to bring some of that stuff back in, most of the stuff. Okay, so it is returned to the blood at the venous end. How is it done that? How is it done that? Direction and amount of fluid that moves is dependent on two types of forces: the net filtration pressure, in other words, the push of the pressure out of the vessel versus the pressure push out of the vessel versus the pressure push of the fluid outside the vessel, which is trying to push fluid in the vessel, okay? That's net filtration pressure. Net filtration pressure, you have fluid inside the vessel that has a pressure. That fluid is going to have a pressure that you can measure inside the vessel. There is fluid in the interstitial space. I mean, that's a fluid-filled space. There's pressure there, okay? Is the fluid in the interstitial space fluid pressure greater than the pressure inside the vessel? If it is, no fluid is going to come out. If the pressure inside the vessel, the filtration pressure, is greater than the fluid pressure in the interstitial space, which is the fluid space outside of the blood vessel and outside the cell, we also call it extracellular space. But since we're not dealing just with cells, we call it interstitial space. So there's a push there, and there's push from both sides. There's a general rule: the push from the inside is more than the push from the outside. So now filtration pressure, which is called hydrostatic pressure, we have an absorption pressure, okay, from the proteins, Remember, the proteins stay inside of the blood vessels. They're too big to get pushed out of those clefts and those fenestrations. So they stay inside the blood vessels. Because they stay inside the blood vessels and because they're hydrated, they carry water with them. And if they carry fluid with them and the fluid's been pushed out, then they have a drawing power. They have a drawing power. Just like if you have if you have something that you're trying to absorb water with, okay, and you want to dampen down the humidity, and you put, my dad had a Martin guitar, it's worth $5,000-$10,000, and you don't want humidity to warp it, so you put drying agents, packets, little drying agents to pull moisture out, okay? So you can think of those proteins as pulling moisture, okay? They have a colloidal osmotic pressure, and they have a tendency to pull, okay? So they are proteins, obviously, in interstitial fluid too, but they're not nearly as many proteins in interstitial fluid as they are inside the blood vessel. So the pull generally is back into the blood vessel. So hydrostatic pressure, force exerts against pressure wall due to fluid pressure, okay? Hydrostatic pressure is higher at the arterial end. So we're talking about hydrostatic pressure of the capillary. That's what that C means. I always have to think about it. Higher at the arterial end than the venous end, okay? Because the pressure's dropping through the capillary bed. And part of the reason it's dropping is being pushed out, okay? But remember, the capillary bed has such a huge surface area, that you've got a certain amount of fluid that you had 10 liters of fluid, and all of a sudden you've got 1,000 ways for it to go. And so you're going to divide that 10 liters of fluid into 1,000 branches, okay? So you get a pressure drop just because of the volume of the surface area. So the hydrostatic pressure is higher at the arterial end than at the venous end as the pressure drops through the capillaries. The hydrostatic pressure of the interstitial fluid, remember that's the fluid between the blood vessel and cell, opposes the movement of fluid out of the capillary. So there's a fluid pressure inside the capillary and a fluid pressure outside the capillary. The fluid pressure is called hydrostatic pressure. Hydrostatic is fluid. So the fluid pressure inside the capillary is pushing against the fluid pressure outside the capillary in the interstitial fluid. And whichever one has the highest number is the way the fluid is going to move. Whichever one has the highest number, obviously, is going to force the fluid to move in that direction. Because remember, the capillaries have these clefts and these fenestrations, these good-sized holes. Hydrostatic pressure of the capillary is about 35 millimeters at the arterial end. Remember, a capillary bed has an arterial end and the venous end. Capillary bed has an arterial end and the venous end. So we're inside the capillary. We have a 35 millimeter hydrostatic pressure inside the capillary pushing outwards, okay? Hydrostatic pressure of the capillary is about 17 millimeters at the venous end. So now we're at the venous end. I wish every diagram they had, well, not every diagram would have the arterial system over here and the venous system here, but imagine this is the capillary bed here. This is the arterial side. This is the venous side. So here's the hydrostatic pressure pushing outside at the arterial end. Here's the hydrostatic pressure pushing outside at the venous end. The hydrostatic pressure of the interstitial fluid in relationship to this is 0 at both ends, okay? So we have 0 at the arterial end, so 0 at the venous end. So if we're just looking at the hydrostatic pressure, we would be pushing fluid out of the vascular system at both ends, at the arterial end and the venous end. So we'd be constantly pushing fluid out in between there. Because if we've got a 0 on the other side, if we've got a 0 of the hydrostatic pressure at both ends, okay, then we have 35 out here, 0 in there, 17 out, 0 in there, okay? But that's not the only pressures we have. Arterial hydrostatic pressure is 35 out and 0 in, 35 out. Venous hydrostatic pressure 17 out and 17 out, 0 in, so a total 17 out. So far, all fluids going out both ends. Concentration of large, non-diffusible molecules, proteins, okay? The number one protein in the blood, if you remember, is albumin. Number one protein in the blood is albumin. We have globulins in the blood, antibodies, number of proteins in the blood. These are too big to go out through the clefts. These are too big to go out through the fenestrations. Okay, these are big molecules. They're going to stay in here. They stay hydrated. Okay, they stay hydrated. So they have a tendency to pull fluid inward. They have a tendency to pull fluid inward. They're not going to go out. They're going to stay inside the vessel from the arterial end to the venous end. Okay, this is a representation of proteins. If you remember when we did cell back in Anatomy and Physiology 1, if we wrote it up on the board, we made proteins as an A, okay? These molecules draw fluid towards them because they are surrounded by fluid. The osmotic pressure in the capillary is 26 at both ends. So the osmotic pressure in the capillary is 26 at both ends. So there is a tendency, because of these proteins, to draw fluid in, okay? Draw fluid in at both ends. So we've got a pressure of trying to push out a 35 and to draw the fluid in at 26 at the arterial end. At the venous end, we got a pressure of pushing out of 17 and because of the filtration pressure and the colloidal osmotic pressure of 26 trying to draw it back in. The osmotic pressure is 1 out at both ends, okay? So for the proteins that are inside the vessel, the colloidal osmotic pressure is 26 in and 26 in at both ends. The osmotic pressure due to the proteins in interstitial fluid. Remember, I told you there were proteins in interstitial fluid, but they were a whole lot less than they are inside the vascular system, is 1 out, okay? So we have, because the interstitial proteins outside the blood vessel, we have a total of 1 going out here, okay, and 1 going out here. So these are the pressures we have. We have on the arterial side, we have a net filtration pressure of 35 out. We have a colloidal osmotic pressure of the interstitial fluid of 1 out. We have a colloidal osmotic pressure of the capillaries of 26 in at the arterial end. At the venous end, we have a net filtration pressure. That's the pressure inside the blood vessel trying to push fluid out of 17 out. We have a pressure of the proteins of the big molecules inside the capillary of 26 in. We have a pressure of the big molecules, proteins outside the vessel of 1 out. When we add these together, okay, we have 35 out and we have 25 in. Well, why do we have 25 in? Well, we had 26 in and 1 out. 1 from 26 is 25. So we have 35 out minus 25 in. So at the arterial end, we have a net arterial pressure of 10 out. So this is maybe where you get tripped out. It's 25. Where's 25 come from? We have 35 hydrostatic pressure trying to push the fluid out. We have a colloidal osmotic pressure of 26 inside the vessel trying to keep the fluid in versus a colloidal osmotic pressure of 1 outside the vessel trying to pull the fluid out. 1 from 26 is 25, 25 from 35 is 10. Our net arterial pressure is 10 out at the arterial side of the capillary. At the venous side of the capillary, we have a net filtration pressure of 17 out. We have a colloidal osmotic pressure from the proteins inside the vessel trying to retain the water or pull water back of 26 in. We also have a colloidal osmotic pressure of proteins outside the vessel and interstitial fluid of 10 going out. That gives us 1 minus 26 is 25. We have 17 minus 25 for a net arterial pressure of 8 in, okay? So at the arterial end, we have 10 out, okay? Our net arterial pressure, net filtration pressure is 10 out. Okay. At the venous side, okay, we have a net pressure of 8 in for a total pressure of 2 out. Okay, for total pressure of 2 out. So most of the fluid that goes out gets resorbed back in. So most of the fluid that goes out gets resorbed back in. We have a net of 2 out. How do we reclaim that 2 out? Well, we have lymphatics. Lymphatics is going to be chapter 20. Okay, and we'll see that it takes the excess fluid that is not reclaimed by the blood vessels and by the capillary bed and any excess fluid that's come out for whatever reasons, and reclaims that and brings that back to the heart, with the exceptions of we have a total net out of about 1 to 1.5 liters by way of urine. Okay, but obviously that gets reclaimed too, and then gets excreted as urine. Okay, so like I say, you're going to need to be able to explain this, and you're going to need to be able to explain what would happen if you change something. So what if somebody is severely malnourished, and has a decrease of plasma proteins? In other words, they're not even taking enough nutrition in to have an adequate number of plasma proteins. Now, obviously, you would have to make up numbers, okay? But what would happen there? What would happen there is that if you had a severe decrease of plasma proteins, okay, then this number here, which is pulling fluid back into the system, you're still well hydrated. You just have a decreased number of plasma proteins. So this number is going to go down. So if you still got 35 out and that number goes down, you're going to have a whole lot more fluid pushed out. And if that number goes down, you're going to have less fluid pulled back in. And what are you going to have? You're going to have edema. You're going to have a whole lot of fluid out into the interstitial space. So your body's going to swell up. And so one of the clinical signs of hypoproteinemia or hypoalbuminemia is edema. And so I would look for, number one, an explanation of this system, and probably the question or what we just talked about as a short answer question. What happens when you have a decrease of one of the components? And really the only component that we talk about are proteins. So there are advantages to being in the lecture. Okay, this is just a schematic that shows what we talked about. End result, about 85% of the filter fluid will be reabsorbed. System picks up the rest. The lymphatic system picks up the less, 1.5 milliliters per minute. Okay, homeostatic imbalance, we get edema. See, there's a unilateral edema. Okay, that's probably related to a lymphatic obstruction, or it could be a tumor. What happens is the lymphatics, if you have a tumor in here, so you had a tumor, a bone tumor, something like that, and cancer cells start being sloughed off into the lymphatic system. Lymphatic is a scavenger system, okay? And they will eventually obstruct the lymph nodes and obstruct the lymphatic system, and you can get edema. When we used to do modified in the old days for treatment for breast cancer has evolved. Before I was a surgery resident, treatment for breast cancer was radical mastectomy, including taking pectoralis major muscle. That was the treatment. That was the standard care. When I was a surgery resident about 40 years ago, it's modified radical mastectomy, which means take the breast tissue and a wedge of skin overlying the breast, and taking the axillary nodes on that side. Well, when we took the axillary nodes, we took the lymphatic system, and one of the problems that the women developed was edema in their extremity because they didn't drain. They still had the capillary exchange, but they didn't pick up that extra 1.5 liters of fluid, okay, that came out. All right. So you can get edema, or there again, if this was both sides, they could have a lack of proteins inside their vascular space. Accumulation, increased capillary function. increased blood pressure, poor venous return, reduced capillary resorption, decreased blood albumin. We just talked about that. We said that might be a question on the short answer test. Obstructed lymphatic drainage, okay? We just talked about obstruction. One of the reasons to get obstruction is either because of a surgical procedure where the lymphatics were taken out. If you had a melanoma, okay, if you had a melanoma in the old days, and especially a deep melanoma, you'd had resection of the melanoma in the lower extremity and a groin dissection. You'd remove the lymph nodes in the groin. Now they do I think they do a lymph node sampling. Okay, they inject radioactive material and see where the lymph drains and then sample those nodes there. But there again, I had been out of active medicine a very long time, so I don't know what exactly they do on things. All right, here's what we're going to do now. Okay, first I'm going to ask if there are any questions. Anybody have any questions? If I can, I'm going to try to turn to everybody, unmute all, see how this works. Anybody have any questions? Okay, we're going to talk about the exam. Okay, the exam covers chapters 17, 18, and 19. Okay, the exam covers chapters 17, 18, and 19.